There you go. Super.
All right.
Okay. Dr. Stout, the floor is yours.
All right, thank you, and welcome. I'm always grateful when busy clinicians voluntarily take out their lunch hour to participate in listening to us talk about something that we're excited about to help you further your knowledge base. Specifically, this Project Echo will talk about the topic of exercise and physical activity. And although we're characterizing this around cancer prevention, when we really talk about cancer and the cancer care continuum across the lifespan, we have to think about cancer prevention for individuals who have had a cancer diagnosis and live beyond. And so we'll talk about, we'll sort of characterize exercise, the evidence around prevention of cancer and around cancer survivorship. This is one of my favorite quotes, and I think it's very important, especially for this population, when we're talking to and about primary care services engaging patients in exercise. Exercise is hard. It's hard for patients to become motivated to want to do activity and exercise. It isn't easy to undertake an exercise program. They may not have resources. But it's also conversely hard for primary care providers to make an exercise prescription that's accurate, it's evidence-based, to know what that evidence is, or even to find those resources in the community. So it would be easy if we had an easy button like an exercise pill, probably would be the most widely prescribed and beneficial medicine in the nation. And hopefully today I can share with you some of the evidence base that makes us say the most beneficial medicine in the nation. So we'll start off with some discussion about the evidence around cancer prevention. And this isn't just going to be a didactic blah, blah about the evidence. What I really want to do is share some tools and resources to help you get an easy button to know what I recommend, how I recommend it, and where the resources are. So very exciting for us. Within the last few years, we have seen the evidence base grow significantly to support the benefit of physical activity and exercise in cancer prevention and control. Specifically, these slides speak to cancer prevention. So when you look at the evidence, most of this is from observational trials. The American College of Sports Medicine convened expert roundtables and reviewed this evidence and published in 2018 and 2019 updates to the levels of evidence and recommendations for intervention with physical activity. And what we've seen over this last decade is a tremendous growth in the strength of the evidence that suggests that physical activity and exercise is in fact preventive for the 7 types of cancers that you see listed here. So there is strong level of evidence, and there were high concordance in the recommendations that physical activity and exercise should be recommended to prevent these 7 cancers. Now, below my little green line there, you see lung cancer hanging out with a moderate level of evidence. And across the board here, what we are seeing is a significant increase in evidence that suggests the support of exercise preventing many types of cancers that you see listed. Now, we have to understand much of this is from observational trials. So we're asking patients to recall their amount of exercise. And we know that people are human beings and they bring a little bit of bias, right? When we ask people to tell us about how much they eat, they tend to underestimate that, or tell us how much they spend, they underestimate that. And when we ask them about exercise, we know they might tend to overestimate how much they are active and perform. But nonetheless, much of this is based on very large population-based controlled cohort studies. These also do tend to be cross-sectional. We send surveys to individuals once a year or every 6 months and get insight on their level of physical activity. But here's the good news. What we see is it isn't just exercise and prevent cancer. It isn't just be more active and move more and prevent cancer. But what we are seeing present in the evidence is that there's a dose-response relationship. And so we understand that to mean more exercise, more reported physical activity actually suppresses the risk even further. So it does matter if you do more exercise or more activity. So we do see a dose response there. And the good thing is that that dose response doesn't erode over time in the evidence. So more actually is better. So how do we encourage more? So some of the questions around the dose response, well, what does that look like? Does it have to be a certain type of exercise? Was that studied? How much is enough? And I would say what we're encouraging our patients to do today is probably not really enough. We want to encourage that gradual escalation towards more. Is there an optimal amount? Is there too much? So these may be questions that you hear from patients. And how many types of exercises or things can I do to get me there? And the answers really do come through, or we see signals towards these answers in the evidence reviews that were done that are articulated in those documents that I shared with you. So most of this evidence was around what we term as leisure time physical activity. Leisure time physical activity, we'll talk about the definition of that, but basically those are the activities that are above and beyond your daily set point. And that can be anything. So the good news is it gives us license to say, it doesn't have to be go to the gym and get on a treadmill or go out and ride a bike. It really is any activity that boosts your level of movement above and beyond your daily set point. How much is enough? The current recommendations are 150 minutes of exercise at a moderate intensity accumulated throughout the week. What is moderate intensity? We define that as encouraging an individual to exercise to a point where they feel like they're breathing hard, but still able to carry on a conversation. So those are the verbal anchors that we suggest for a level of exercise that suggests they're at a moderate intensity level. Doing more is associated with an even lower risk. So the dose response relationship. Can you do too much? Well, that's an interesting question, I think. From the level of evidence that we've looked at, no, you can exercise all you want. But from the patient perspective, I'm going to bet my bottom dollar what you all hear is, I tried to exercise, but oh, my back, oh, my knee, oh, I don't have time. I don't have anywhere to exercise. So the can I do too much has to sort of be contextualized with the patient's individual setting, their behavioral characteristics, and so that we can really help them to optimize if there are physical impairments that they're facing. We don't want them to diminish the level of exercise because of those barriers. So we have to think about barriers and how we can get them over that so that they can achieve that increasing and escalating amount of activity. And a broad range of activities were reported across these studies. Household work, work activities that require people to be active, walking to work, walking up and down stairs at work, those types of activities. So these are the two major publications that came out of this. These were evidence reviews. One was driven by the National Cancer Institute, Cancer Prevention and Control, led by Chuck Matthews and Alpa Patel. The other was the American College of Sports Medicine Roundtable Report. Both of these are available open access for you. At the end of my slide, there'll be a whole bunch of references if you want to go out and look for them, but there are some places that you can go to find those references in one place for free. So leisure time activity, what is that? Leisure time physical activity. From a moderate intensity perspective, this can be walking, going out and taking a walk. It doesn't have to be a high intensity walk or a long duration 2-hour walk, but just getting that extra bit of activity in each day. Vigorous activities, more so like hiking, jogging, swimming, tend to be a bit more vigorous. This is a great resource for you. If you want an easy button and you're looking for these materials, Exercise is Medicine is an initiative of the American College of Sports Medicine. And since these new roundtable guideline publications have been published in 2018, we have started a new element involved with EIM, which is Moving Through Cancer. And the Moving Through Cancer Task Force has compiled resources that are free and open access for you. This little diagram, cartoon, schematic, infographic that you see is one of those. You can go on, you can download this for free, print it, excuse me, you can make sure you laminate it. If you're going to hang it in your clinic, you don't want the Joint Commission coming after you, but laminate it and hang it in your clinic. You can have this in your waiting room. You can have it in any of your patient treatment rooms. We've had a couple of places that develop little pins that say, ask me about exercise. And this gives a real nice sort of synopsis about the evidence around cancer prevention. Now, a lot of times also we have to think about that patient population going through cancer treatment. And unfortunately, we have this historical perspective over the last 30, 50 years that people with exercise are fragile and we shouldn't push them too much. They should rest. That is what's best. But in fact, what we have learned is that exercise can mitigate consequences related to cancer treatments, not just while they're going through treatment, but really through survivorship for the rest of the lifespan. So when we're thinking about cancer prevention and control, we've got to think about those individuals during and after treatment. The fact of the matter is we have a significant and growing population of individuals surviving cancer. That's great news. Upwards of 70% of individuals will make a 5-year mark, will make that magical 5-year mark after their diagnosis and treatment for cancer, which means their chances of living the rest of their lifespan are great. Good news, right? The bad news is these individuals deal with chronic morbidity related to cancer treatment that impacts their ability to go back to work, perform their social functions, perform their home activities and their activities of daily living. Upwards of 70% of these individuals will experience at least one impairment that prevents them from getting through their day. So when I think about exercise for cancer prevention, I think about this entire continuum really, because we have to think about the cancer survivors, folks going through cancer treatment, living beyond, and dealing with the side effects and impairments. The other reason that that's important is for us to think about characterizing impairment and how we use exercise to get past impairment, because it's not going to be unusual for us to see someone who has diabetes and a neuropathy that may prevent them from exercising, osteoarthritis and knee or ankle pain that will prevent them from exercising. So characterizing the evidence from an impairment-based perspective, I think is going to be helpful. So what do the guidelines say? I'm not going to go through these in depth. These are great resource slides for you to have. But as we did the evidence review, again, this is the American College of Sports Medicine guideline review committees. I had the chance to participate in these over a 3-year time period of reviewing the evidence. There is strong evidence for symptom or impairment management for the symptoms that you see listed in this chart. So the level of evidence was strong, meaning that there were large randomized controlled trials that showed benefit to influencing these impairments. These were for anyone during or living beyond cancer treatments. So fatigue, one of the most prevalent issues and impairments that we see related to cancer treatment, not just while people are being treated for cancer, years beyond, they can be suffering with chronic fatigue. Physical function, reduction of anxiety and depression. The good news is when you look across these, there's aerobic-based exercise recommendations. There are also some resistive-based exercise recommendations. So that gives us license to say to a patient, you choose what you would like to do. How can we help you engage in a program that helps you get these elements? Something else I want to point out about these guideline review papers, when we looked at these recommendations, these studies, the majority of them were in supervised settings. So just giving a patient a piece of paper and saying, hey, here you go, here are some exercises may not be good enough. The supervised exercise programs tended to have superior outcomes. Moderate evidence was identified for exercise prescription in bone health and improving sleep. And then I think this is the exciting slide. This is where there was insufficient evidence, but there were studies suggestive of a positive signal in the benefit of exercise. So for me, I look at this and I think, oh, this is where the emerging evidence is coming. Cardiotoxicity issues, cognitive function, falls. So these are areas where there were smaller studies, perhaps not controlled case series, single arm studies, but just not really rising to a very strong level of evidence. So insufficient evidence doesn't mean that the patient won't benefit. It means we may just not have the right large studies to tell us what that specific prescription should look like. So great. If you are, however, looking at implementing this into your practice, we have yet another publication that came out with this guideline review, because we said as a group, it's great to publish a guideline, pat yourself on the back, great. But what we really want is to see this implemented into practice. And so this graphic and this entire premise of assess, advise, refer is where we have tried to move the field to. We're working in medical oncology clinics. We're working in primary care clinics to help to implement this premise. From your perspective as a primary care provider, are you going to give them a specific exercise prescription and have those resources? You may or you may not. And we're betting that the easy button for you is to assess with a simple physical activity screen, 2 or 3 questions about their level of activity. Are they interested in getting more information about exercise and activity? And if the answer is yes, advise them about what is the minimum and then refer them to the best available program in the community. And that can mean different things for different people. So on your EIM website, the Moving Through Cancer, you also see this nice little prescription pad. Patients love to leave with a piece of paper in their hand. And so you can get those prescription pads there also for free. I know we're mostly on our electronic medical record systems, but that's a nice way to send the patient out the door with some specific guidance. So when we are making that assess, advise, refer, physical activity as a vital sign is a validated screening tool. 3 questions about the individual's interest and level of activity currently. But then we have to think about, great, where do I refer them to? Can I just send them to a 24-hour fitness? Should I be looking for a physical therapist? Is there something in between? Where do I send the patient? That's where the risk stratification profile becomes more important, because there are certain age-related comorbidities, cardiometabolic comorbidities that need to be considered when we're recommending the exercise program. We should also be able to assess the environment in which the patient lives and works and understand how that influences their ability to be active, and understand the behavioral factors and patients' preferences and lifestyle choices that will help to motivate them towards an exercise prescription. I don't know that our primary care professionals have the time or the interest or the ability to complete an entire assessment, but assess, advise, refer, get them to the place that is most capable of doing a more detailed assessment of that individual's functional capabilities and physical activity levels, and begin to work with them to create that program. So we created this relatively simple matrix, and we've seen this implemented into the EHRs across several practice sites that we've been working with in implementation. So the very first question, and when you do the physical activity as a vital sign screen, tells you, do they meet the physical activity guidelines, 150 minutes accumulated throughout the week? And if the answer is no, the next question should be, are you interested in receiving information about becoming more active? And sometimes we've learned the answer is no. No, you know what? I have too much other stuff going on right now. It's not something I'm interested in. And you know what? That's okay. That patient does not have self-activation to move towards this activity. So why force it? But it doesn't mean that I'm going to just erase them from my memory. The next time they come into the clinic, I'm going to reassess and I'm going to ask them again, are you interested? And that answer may change over time. You know, I've thought about it, and, you know, maybe I could think about doing something. And so this really takes you through an algorithm that looks at the level of intensity of intervention that an individual might need. Some people have very high motivation, but have a lot of impairment. I'd love to be able to exercise, but my back pain, my knee, my neuropathy and tingling in my feet, I don't feel safe to exercise. So they may fall on the higher end of the spectrum of needing a little bit more supervision and oversight in an exercise program. Others may be very motivated and have a very low level of impairment and have an interest and a place to engage. How can we encourage their participation through? Maybe there are virtual applications, mobile health, exercise prescriptions that we can deliver to them. And there's a lot in between with fitness facilities who have a cancer exercise specialist or exercise specialists who are trained in impairment management. So before I turn over to Megan to talk us through a case, what I want to share with you are some of the Moving Through Cancer resources. As I said, we really wanted to create simple tools that are easy for you to access, free, things that really simplify what can you do for aerobic activity? What can you do for strength training? How do you get started? How do you build a plan? How do you create and facilitate the motivation? What types of physical activity could we encourage in our patients? So I will go ahead and stop sharing my screen and go ahead and shift over to Megan.
Before we head over to our case study, did anybody have any questions for Nicole about her presentation?
Oh, and thank you. I see Mary Ellen populated the chat with those exercises medicine. Please use those. We went through patient testing. There's actually a patient-facing booklet that's going to be coming out. Again, free. You can access all of these for free. If I always say if it's free, it's me. Man, I'm on it.
Nicole, the only one that I didn't see was the first one you showed that had the assess, advise, refer.
Yeah, I think that's in a physician-facing document. I think it's embedded within one of the papers, the documents that's there. Yep.
Any questions, reflections for Dr. Stout and her presentation? Okay, well, thank you. I loved all of the graphics. To me, such an easy way to see what the process looks like of the short game and the long game. So thank you so much. All right, so Dr. Burkhart, I'm going to get that case presentation up here for you.
Good.
All right, can you see that? How's that?
That's better.
Okay.
Okay, so I've taken this from more of a medical provider outlook than a PT evaluation, just to kind of help show what I think is the typical patient that would show up in an outpatient PCP setting. So this is a 56-year-old postmenopausal woman with a history of right breast cancer that presents to your clinic with a complaint of fatigue, globalized joint pain, and stiffness. Her pain is more significant in her hips and her hands. And in the morning, when she tries to get up, she can barely walk into the bathroom or grip her toothbrush to brush her teeth. The most common thing you hear is, I feel like I'm 80. She considers herself physically active prior to diagnosis, walking 2 to 3 miles a day, or at least 4 days a week. And now she's having difficulty completing even her daily activities. She notes that she saw her medical oncologist 4 weeks ago and that all of her imaging was normal, and that her oncologist said she was doing great and she doesn't need to return for 6 months. Comorbidities, her cancer is listed there. She had neoadjuvant chemotherapy, a lumpectomy with sentinel lymph node biopsy to surgically remove the cancer, and then radiation. She was borderline obese historically, but with her last visit, so she hadn't been under the BMI scale, but she's now just above it with a BMI of 29.8. She has mild IBS that she controls with food. Her review of systems, she has musculoskeletal. She has a positive result, complaining of muscle pain and joint pain. She's not showing any other signs of or fear of reoccurrence. So like night sweats, no bone pain. She denies any new lumps or masses in her breasts, any changes with that. She denies headaches, but she does say that she has neuropathy in both her hands and feet. She denies any frequent bruising or blood loss. When you take a look at her, everything for on her skin looks great. Her neck looks great. Her heart sounds great, and she has a regular rate and rhythm. Her chest sounds clear. Her breast exam showed what findings you would expect for somebody that had gone through the treatment. She's not showing any signs of swelling in her upper or lower extremities. The gross exam on her neurologic system is normal except for bilateral neuropathy. She's otherwise relatively upbeat. Her behavior is normal. She seems to be down about the fact that she is having so much trouble, and that despite being painful, her oncologist thinks she's doing fantastic. You reviewed her labs and imaging, and that is all normal. She's on very few medications. She's just on an estradiol once a day, which is a hormone blocker. She's on calcium and vitamin D. So I had some questions to create a discussion around this case about what you guys would do with her, what you feel comfortable doing with her, how you would recommend exercise, and where you would send her. So my first question was, what other treatment-related impairments could be contributing to her chief complaint? So weird that I can't see you. I'm gonna make you guys talk to me. It's awful.
And you can just unmute and share. If your microphone's not working and you want to type in the chat, that's okay too.
And would it be helpful, Andy, if you scrolled that back up so they could see information about the treatment, prior history of the patient?
Yep, I can go anywhere on the screen you'd like me to go.
So I think one of the things that I think is common there, and you can correct me if I'm wrong, there's not a huge relay of information about the cancer treatment to PCPs or to other healthcare providers. And so I kind of purposely left her treatment vague as far as what chemotherapy she got, how much radiation she got, that kind of stuff, because I think that most of the time that doesn't come along with the patient. And that is the key to kind of looking at what is the cancer related sequela versus possibly some other issue going on. So for this patient, she probably would have gotten a neurotoxic agent, either with Taxol or carboplatin. And her radiation would have been standard at 16 weeks. So, but the carboplatin or Taxol would be part of why she was having neuropathies in her feet and her hands, because it's normally in a glove stocking pattern. So do you feel like there's any contraindications to prescribing exercise for her?
I wouldn't say contraindications. I guess I would say, and I think this is a really important take-home point, right? There's something for everyone. Everyone needs something. It's just gauging how we would make that prescription based on her presenting symptoms, her limitations, and her willingness to sort of gradually move through an exercise program. Definitely some precautions that I would think about.
Yeah, that was a little bit of a trick question. And that I would say the exact same thing, which is, everybody can walk. You do it all throughout your daily activity. So if we can always begin safely with a walking program and progress up from there. Do you think the patient needs a referral back to her medical oncologist to deal with this, or do you feel comfortable making the recommendations yourself? And that is really kind of the crux of this, not only for I think in the medical field, but also for in the PT or rehab world, is trying to figure out how comfortable general practitioners are in dealing with cancer-related sequelae. Sorry, I missed that chat.
Yeah, what type of exercise would you suggest for a patient with limited mobility?
So for me, looking at this case, what the things that are popping out to me that are most important is to figure out first, if this is something that is just a treatment related side effect, or if it could be the signs of a progression in disease. And to me, she looks like it's just the sequela of treatments, and so it's moving forward with what she has. So I would say that there's no issue in recommending that she get active, and she has been active before, which is exciting, because then you have somebody that knows how to exercise. I hesitate when people just tell people or their patients to become physically active. If they haven't been active before, they have no idea how to do that normally. And now that they're dealing with additional side effects from cancer, they're definitely not going to know how to do that. So that would be somebody that I would recommend to either an exercise specialist or to a physical therapist to get started. So for her, it would be, I would go for an exercise specialist if she's not falling. So depending on how bad her balance is and how much that is limiting her motion, if their balance was bad or she had a fall, then I would go straight to a PT first and then let them send to an exercise specialist from there.
Looks like we do have another question in the chat.
Okay.
This is a good one too. How often should an individual take a break from sitting at their desk and standing to improve the mobility, and for how long, for someone that's maybe not currently very active?
Yeah. So when I first start a patient that has not been active, I really limit how much they go so that they're successful and happy and likely to do it again. And so even if it's getting up and walking for 2 or 3 minutes at a time, if that's the limitation of fatigue, then that is a beautiful place to start. And I would rather see multiple, like short duration exercise in the beginning, multiple times a day. Again, make it successful, make it happy, and they'll want to do it again. And so I want it to be in the very beginning light and easy, and then ramp up slowly from there. That's where an exercise specialist is a great place to have somebody advance, so that they are watching how they deal with it. But if the patient wants to do it on their own, I tell them when something feels good for 3 days and there's no change in it, then that's when it's time to add a little bit more time to your walk. And then same thing, as soon as that feels good for 2 or 3 days, then go up small amounts from there. And that usually does it very nicely. And then with all of the with the hormone blockers, we're also worried about bone density and bone health long term. So we want to recommend that they do load bearing exercise versus something like swimming or bicycling, where they're going to be unweighted, because we want compression through the bone. So that becomes a good recommendation as well.
I also think about the saying we've heard recently, sitting is the new smoking. And in fact, the effects of sitting are very substantial on deconditioning, bad joint health. So in general, I think about and have been using lately Tabata intervals. And the idea behind a Tabata interval is a short duration activity. Just like Megan said, you stand up and you do something for 20 seconds, and then you take a little 10-second break. Then you do something else for 20 seconds, you take a 10-second break, and you do this sort of off and on. It doesn't have to be a high intensity activity. It can be standing up and marching at your desk for 20 seconds, take a little break, standing up and doing some squats for 20 seconds, take that little break. But I think that idea of that intermittent little bouts of exercise, that doesn't seem threatening, right? I'm not telling them drop and do push-ups for 20 seconds. That could be an activity though. But there are simple things that can be integrated throughout the day. So stand up, do those activities maybe once every hour would be optimistic. The other thing that Megan and I will tell you is sometimes we tell our patients, I want you to do this every day, 3 times a day, 4 times a day. And we hope that they're going to get to it once a day. That's kind of one of the ways we structure our little nudge insights to increasing people's activity. Because the truth of the matter is, if they're doing 0 right now, we can only help them to tear up from here.
One of my favorite recommendations, and I do it myself, it's more of a stress relief for me, is a 3-minute dance break. On a stressful day, twice a day, I'll take a 3-minute dance break and I'll put my headphones in and shut my treatment room door. And I'll put on something that makes me really happy. And I will dance. And if it's a bad day, I may sit on my stool and dance, but it's at least some movement. And that's a really easy recommendation for most people that does also improve their mood and affect because it feels good.
Nicole, do you have a like a link or something that you would share, like what those Tabata intervals would look like? Because to me, that sounds like something that would be an easy share, even through an electronic health record.
Yeah, absolutely. The other thing that Megan just said that I think is so important is, you know what? You're not going to want to do something every day, and that's okay, right? Just because you say, screw this today, I'm not feeling it, I can't get up, I don't have the energy. That's okay, right? It doesn't mean that you've fallen off, that you can't continue your program. Some days you're not going to feel like doing it. Some days you're going to do 10 repetitions of something and be like, I'm done. You're going to walk for 10 minutes and say, gosh, yesterday I did 30 minutes and I can't do it today. That's okay. It's not just going to be this, onward linear progression. There will be peaks and valleys. And I think that's a really important point to emphasize too, that I want to be accepting that someone's trying to exercise, trying to do more physical activity, and say, it's okay, take a break for a day or 2. And maybe the motivation's not there, maybe there's pain, but step back and that's okay too.
I think especially when you're dealing with some of the side effects that come with aromatase inhibitors and hormone blockers, it's not just that there's joint pain, but there's also a little bit of emotional lability. So, the hot flashes and hormonal changes. So, and women tend to not be very nice to themselves anyway, as far as being critical of their activity. And so I lay things out like, I don't want you to go to Gold's Gym and get a gym membership right now. I don't want you doing anything that really is going to hurt you or keep you from doing the things that you love to do. And so I think also it's a little bit of normalizing that, it's not abnormal for you to only be able to walk for 5 minutes. And if it's 5 minutes, we're going to celebrate 5 minutes. And because, right now you're fighting a chemical that is keeping you from moving. So that it kind of takes some of the onus off of them to go at it wholeheartedly and because then they won't get back to it.
The one question that you asked earlier was, should this patient return to their medical oncologist about this treatment? And I was just wondering if anybody on here had thoughts about that, because I would imagine that that's one of the bigger challenges in this long game.
So I can give you from what I see or I hear from my patients, and I think is a frustration that providers also have to feel, which is that the medical oncologists are really trying hard to focus just on the cancer. And so when it comes to things like pain and fatigue, they say, we'll talk to your primary care about that. And so they kind of push that off to them, but then the primary care physician doesn't exactly know how to treat that and what the best way of doing it is. And when one of those treatments is possibly changing the hormone blocker, I think it would be hard to make that choice. But I think more and more as the medical oncologists get busier, it is pushed to a primary care physician. So I'm not sure what the right answer for that is, or what a physician's experience would be. But that's what I hear a lot, the patient's frustration.
I wish my primary care doctor was on here today because I would make her answer.
I think in a lot of the scenarios, it comes down to, do you feel like you have adequate information about the patient's cancer treatment care plan? Do you understand the toxicities they've experienced, and how they're progressing through treatment? And if you, and what I've heard from a lot of our primary care professionals is that they don't, you help to make a diagnosis of cancer, patients go in and they go through treatment, and you're only really seeing them back in your office for routine follow-up visit, and you may not have that full perspective on what has happened. And so I think that breeds hesitancy in your willingness to say, yeah, let's start an exercise program, or let's try a nutritional intervention even, because you really don't have good insight on what that care plan has looked like, or the toxicities that these individuals have experienced. And I think that's another topic, but something I think that could be a facilitatory mechanism if we had better connectivity of communication and awareness around what the care plan was, what the patient experienced, and then what the care plan should look like going forward. What might be those red flags or those concerns. I think sometimes we get very nervous. We know especially with breast cancer, it is a bone avid cancer. And, something like new pain with weight bearing is a red flag that makes us go, whoa, am I concerned about metastasis to the bone here? Joint pain even could be raising that flag. So I think it's understanding sort of the cluster of symptom presentation, and then also understanding what treatments the patients had and how they've responded, and where they are in the trajectory of follow-up. But for the most part, my suggestion is, let's try something for a couple of days, weeks, see how we go. If the symptoms are escalating, maybe that's when I would suggest the referral back. If things are starting to improve or attenuate, let's keep going and see, how we do in the absence of red flag symptoms.
Okay, we have about 10 minutes remaining. So does anybody else have any thoughts or questions for Dr. Burkhart or Dr. Stout before we move on to our wrap up? Okay, Dr. Stout, you had mentioned wanting to do sort of a wrap up at the end. Are you good for that now?
I just wanted to ask those individuals who are with us today what their thoughts are on, do you feel like you have community resources that you can access to get your patients connected, whether it's cancer or not? I mean, just do you feel like you have those connections in the community where you can confidently say, if I really wanted to encourage someone to exercise and I know they needed medical or some type of supervision, I know I could send them here. Do you have a fitness facility that you've worked with that has professionals that you feel comfortable with? Do you have rehabilitation professionals, I guess? Or do you feel like, help me find these people, tell me, because one of the things Megan and I are interested in is capacity building around the state. And we would love to work on education of workforce, whether that's exercise professionals, rehabilitation professionals. So what do you have out there? Is it working for you? Or are you just in a resource gap?
here in Summersville, we have a couple physical therapy places that we can call on. We have a couple of gyms and they offer trainers. Of course, that's for a lot of people not feasible because of the cost. When I work over in the Richwood area, though, there's nothing. And it's a good 45 minutes to an hour to get over here to Summersville, and a lot of people don't have that transportation. So that's our biggest issue.
In Franklin, West Virginia, Pendleton County, we have very little. We have one physical therapy group, but they're affiliated with the nursing home. So they do inpatient and outpatient, and their time is limited. Right in Franklin, we have two small gyms, but no trainers associated. And these are very small, kind of hole in the wall places with very few machines. And then the other two kind of towns in Pendleton County, which are about 45 minutes from Franklin, have nothing. So we have very little here. And we have no safe walking trails, no rails to trails, nothing. Not even all of our roads have sidewalks. We are rural, so people can hike up the mountain on their farm, but nothing formal.
And there are times, even for me, like I have an 88-acre property. I just go out and walk around the field. And that's what I tell folks. I'm like, even just that is walking. But I think I'll highlight several years ago, you may be familiar with, this was actually more than a decade ago, there was an effort to promote an exercise program for cancer prevention and control through the YMCA. It was called Live Strong at the YMCA. And there was an effort where there was funding from the Live Strong Foundation. Across the country, Live Strong programs were developed, and it was very hit or miss as to whether or not those were sustained. And unfortunately, here in West Virginia, we had 0 Live Strong at the Y programs. However, we have a pretty robust network of YMCA facilities. Do you think it would be amenable to you, to your patients, if there were individuals at a YMCA perhaps who were more educated about exercise for individuals with impairment? And cancer is part of this, of course, or, we creating a cancer exercise program. Is that a resource that's available, or is that beyond what you think people or resources that you have available?
We do not have a YMCA. The nearest one is in Randolph County, which is an hour and 15 minutes and 5 mountains between us and Elkin. So that's probably not going to help.
I wouldn't be making that drive.
Well, if anyone has other thoughts regarding that, you can always reach out to our presenters today or to us. And we would love to have you. Oh, Mary Ellen, that shared the safe link. I hate it when it does that. So we're going to go ahead and wrap up. I'll just share one last slide so that you can see what's coming next. October 25th is the basics of cancer genetics. And if any of you on here, if you have a case that you'd like to present, it doesn't have to be about the topic that is the didactic for that day. Our goal is to build a community of providers and partners so that we are a resource to one another. So if you have a case not related, you can always email me. I can get you the case study form. It's very simple to fill out. We would love to have you. We do not have sessions in November and December because of that last Tuesday of the month is holiday time. So we'll be sending out some information maybe to find out what are some things we can do better, or what are you looking for? And then we pick back up in January and February with immunotherapy and then cancer screening guidelines. We will, if you signed up for CE today, there will be a follow-up with Mary Ellen. A couple people did ask, how does that work? How do they receive that CE credit? I know you submit it. Then how does that get to the person who's receiving it?
I'm going to ask for Mitra or Elizabeth's help with this, because
Okay, good.
this is the first time that we've had to do this process.
Sorry, that was my phone, my office phone.
And Elizabeth, if you started to talk, you were on mute.
I didn't know if Mitra wanted to take it or or Jay or me, so no worries. Okay, so basically the CE office takes care of it. When you take your attendance, these individuals, when they sign up, at least through our REDCap, it links them to the CE office's form so that they're within their system. And then I will get a kickback notification because I told them I wanted to have that, so that I know that that individual has filled out that form. And from there, when we take attendance and we turn that into the CE office, that is when they will do it on their end. And they'll,
Okay.
sometimes have to like communicate and ask us questions. If people want their transcripts, we have a link, they can do that and they can contact the CE office to obtain those transcripts. But they are sometimes a little bit behind. So like just bear with the patience there. But that's how we usually utilize it. Did I miss anything, Mitra or Jay?
No, you got it. Thank you. And
Yep.
so I chatted into the link that they actually sent to us. So I think if you click that, it'll take it to our Echo specifically. If you'd like, we can reach out to the CE department. They'll probably create a specific form for you all and all of your Echo. And moving forward, maybe in the recap email, you guys can send it out so everyone who attended today's session can click that specific link and not necessarily the one I chatted in. But if you all wanted to click that and kind of see what it would look like, you're more than welcome to do that.
Okay. Yeah, Mary Ellen is submitting all of it, but
Excellent.
the
Yeah.
question was then how does the person prove that they received it?
Oh, yes, there's a specific transcript website that they should go to retrieve their CE transcript. So that I can also chat in, or I can also send it to you, Andy and Mary Ellen,
Okay.
to also include in the recap.
Yeah, that would be super. Thank you.
Yeah, absolutely.
And
Yeah.
thank you to those of you that asked those questions, because these are the kinds of things that we don't know. Sometimes we don't think about it till you ask us, and we get better every time. So if nobody has anything else, thanks so much. We'd love to have you at all of our Echoes, and hopefully we'll see everybody in October. Have a great Tuesday.
Thanks,
Thank you.
everyone.
Thank you.